This presentation is entitled In Vivo Correction of Dystrophic Epidermolysis Bullosa by Direct Cutaneous COL7A1 Gene Replacement, Results of a Phase 1-2 Trial. And this is presented by Peter Marinkovich from Stanford University. Dystrophic epidermolysis bullosa is a severe genodermatosis caused by mutations of COL7A1, the gene coding for type 7 collagen. And without collagen 7, the epidermis cannot anchor itself to the dermis. Clinically, it's characterized by widespread blistering and erosions which occur in response to minor trauma. It produces debilitating scarring as it heals, and it can produce total disuse of the hand, the condition called pseudosyndactyly. It can also produce severe squamous cell carcinoma that can be lethal, and it's the main source of mortality in the severe patients. There are no approved corrective therapies for dystrophic EB. Supportive therapies are the only ones that are currently approved, and they can range between $200,000 and $400,000 a year annually due to extensive wound dressing changes as well as other ancillary services. This presentation describes a novel approach to gene therapy utilizing a topical in vivo vector that's called Beramagine Geperpavec, or BVEC, which is a replication defective HSV1 vector containing two functional COL7A1 genes that are applied directly to EB patient wounds in an outpatient setting. This was performed at Stanford University and sponsored by Crystal Biotech. This therapy is a topical formulation that can be applied to multiple wounds, and it's applied during wound dressing changes. As an off-the-shelf product, it can be shipped anywhere in the world and does not require extensive cell engineering or manufacturing. It's not dependent on patient cells. It can be administered under basic conditions, doesn't require an OR, it doesn't require hospitalization. It can just be done, ultimately it could be done at home. That is the hope. So one of the reasons why I'm excited about this therapy is that it has the potential, because it's so easy to distribute and administer, it has potential to reach a lot of patients around the world. The study was an intra-patient comparison of wounds that were randomized to receive either the topical BVEC or placebo gel. And phase 1 wound was administered. In phase 2, additional wounds were administered, as well as extending of the trial to 3 months, and dosing range was also increased. Efficacy was assessed following wound closure, and durability was noted. Safety was assessed through adverse events, as well as laboratory and physical exam findings. Viral shedding was analyzed through swabbing and collection of blood and urine, and HSV1 and collagen 7 antibodies were also assessed through serum collection. The results of the safety to date is that this product, BVEC, continues to be well tolerated to date following repeated dosing. We have not noted any severe or treatment-related adverse events. No inflammation at the local sites of administration, no systemic viral shedding, no adverse events associated with labs. We noted that some patients had collagen 7 and HSV1 antibodies prior to therapy, and this did not impair either efficacy or tolerance of the therapy. As far as mechanistic data, the product showed a very dramatic ability to promote durable wound healing. So once the wounds healed, we saw a nice durability of the healing for many months, as illustrated in this result of a wound on patient number 9, compared to the placebo wound, which showed a a lot of dynamic activity is what we call a recurring wound. Not only did BVAC work well on recurrent wounds, it also was shown to be effective on chronic wounds. This shows patient number 3 who had a chronic wound of greater than 4 years duration on the foot, the dorsal foot, and following the first treatment, some healing was noted, and then the patient was brought back for a second course of treatment, which then resulted in the healing of the wound within the first month of the second treatment, and then a durable wound healing afterwards for several months, and even past the study termination. This is the last patient that was enrolled into the trial, a patient that had chronic wounds that covered almost the entire left side of his torso, and had been present for greater than 5 years. And we show 1 year prior to baseline what the appearance looked like on baseline, and then after therapy was terminated at day 84, we saw a substantial improvement in this highly chronic, highly extensive wound. So of the different patients who entered this trial, this was the only patient who didn't completely heal this wound, but showed substantial healing nonetheless. This demonstrates a collagen 7 expression following healing of the wounds in the presence of BVAC. As you can see, we see both NC1 and NC2 domains of collagen 7 localizing in a linear basement membrane-like pattern on frozen sections of skin. You can see by the arrow where the basement membrane zone is located. And then this is in another patient showing the same thing with collagen NC1 and NC2 antibodies. And you see both at day 15 as well as day 97 following the therapy, continued robust staining for collagen 7. And this shows actually tiling images where we took multiple low power sections and pieced them together to show a very extensive area of skin, to show that the long stretches of linear full-length collagen 7 expression was noted in these patients following BVAC therapy. Looking at the electron microscopy level, we could see that baseline, this is the typical example of a patient, this is patient 10, that showed minimal staining of NC1 that you can see by the arrow in the left-hand upper panel. The little black dots show the expression of a dysfunctional fragment of collagen 7, which is often produced by these patients, and a total lack of NC2 staining on the lower left-hand panel. On the right panels, this is post BVAC therapy. You see a substantial increase in NC1 staining in the lamina densa. You see a substantial increase in NC2 staining, which is about 300 nanometers away from the lamina densa, and the typical pattern expected from normal skin studies. You also see the beginnings of anchoring fibrils coming out from the lamina densa perpendicularly, intertwining with the interstitial collagen fibrils of the dermis. And then with further maturation by day 97, you see these are maturing into banded anchoring fibrils, which are indistinguishable from what normal patients show. So we see that the therapeutic gene product not only correctly ultrastructurally localizes in the correct orientation, but it also supports the assembly and maturation of anchoring fibrils, essentially correcting the molecular defect in these patients. As far as statistical analysis, we can see that while the placebo wounds fluctuated due to the recurrent nature of many of these wounds, we see that the treated BVAC or KB103 treated wounds slowly and steadily heal and then remain healed over long periods of time, up to 12 weeks of the time that were studied. And this is statistically significant with a p-value of less than 0.05. We performed additional wound closure studies and we found that by looking at numbers of wound closure of greater than equal to 75%, greater than equal to 90%, and greater than equal to 100%, looking at both active and placebo on a weekly basis, we can see that the wound response closure was statistically significant with a p-value of 0.05 for all the endpoints measured. In the forest plot of looking at wound closure active versus placebo weeks 8 through 12, you can see that the wound closure response is statistically robust with a p-value of 0.0001 with all of the endpoints after adjusting for week-to-week placebo variability by stratified CMH test. So in summary, BVAC is a product which is being developed as a topical gel to treat patients with dystrophic epidermolysis bullosa, and is designed to be applied by physicians or local caregivers. BVAC has received Regenerative Medicine Advanced Therapy or RMAT designation from the FDA and Priority Medicines Prime designation awarded by the European Medical Agency. Clinical data to date shows that BVAC is significantly improves wounds compared to placebo between weeks 8 and 12. We show a lack of safety or tolerance issues even upon repeated application, and there's currently a design of a phase 3 study which will closely align with the study design of the phase 1/2 clinical trial. And with that, I'd like to just thank all the members of the teams from both Stanford as well as Crystal and Portland research unit in working together to form this really exciting new therapy for epidermolysis bullosa patients. Thank you.